CDC. And today we're going to have Dr. Richard Mugambe, who is a lecturer and researcher in the Department of Disease Control and Environmental Health at Makerere University College of Health Science in Uganda. He's also had he holds a PhD from the University of Ireland Trinity College in Dublin. He's a public health researcher with a keen interest in environmental detriments of health. His area of research focus including environmental, microbial, and chemical exposure, neglected tropical diseases, as well as water, sanitation, and hygiene, especially in the institutions. So I'm going to hand over to Dr. Richard. Dr. Richard, welcome, and thank you very much for being able to be with us today. You will be able to share your screen, and then you can start with your presentation. Thank you very much.
Thank you, Anna, for that introduction. It's a pleasure to be part of this session today, and I'm happy to interact with the different participants that we have here today. I'm trying to share my PowerPoint slides, and I'll be done shortly, and I'll be able to start my presentation. So once again, I'm Richard Mugambe, and I'm a lecturer and a researcher at Makerere University School of Public Health. And my talk today is specifically on IPC, infection prevention and control, as well as WASH in healthcare facilities in Uganda. And specifically, I will be focusing on activities, measures, and some of the ongoing research that we are doing now. In terms of my presentation outline, I'll give a little bit of an introduction, and then I'll dive into some research gaps. And then after that, I will look at some previous and current IPC/WASH activities in Uganda, and then I will share with you some of our current, some of our research findings. So infection prevention and control, as well as water, sanitation, and hygiene in healthcare facilities are critical for quality healthcare service provision. But unfortunately, in many low and income countries like Uganda and many of the countries where many of you here are coming from, the IPC and WASH infrastructure is poor, and because of the poor IPC and WASH infrastructure, we find ourselves in many of the healthcare facilities with a preventable risk, especially to those that are providing the healthcare services and those that are seeking the healthcare services. Specifically here, mothers are at risk, a great risk of acquiring the healthcare acquired infections, as well as the newborns who are usually at even a higher risk of acquiring the healthcare associated infections, especially when it comes to sepsis. However, unfortunately, research on IPC and WASH in healthcare facilities is still limited. What are some of the gaps when it comes to IPC and WASH in healthcare facilities? First of all, the contribution of poor IPC and WASH to nosocomial infections in terms of the burden of disease and how it is linked to IPC and WASH is not yet fully known. Secondly, the most effective WASH interventions in healthcare facilities have not been fully documented. We have a lot of evidence from the general population or the general community, but we don't have many interventional studies that present real evidence on effectiveness of WASH and IPC interventions in healthcare facility settings. Thirdly, the cost effectiveness of IPC and WASH interventions is not documented. IPC WASH needs across different levels of healthcare facilities still need to be explored. Issues related to coverage and quality of eyepiece and wash in healthcare facilities. How to provide sustainable eyepiece and wash services in healthcare facilities is still a challenge that we need to explore further through research. If I may give my personal observation, in Uganda, we've had NGOs and many other stakeholders that have provided wash and eyepiece infrastructure in healthcare facilities, but the sustainability of these facilities it has been a problem. After a few years, they break down, and that is it. And then you have to wait for another stakeholder, another donor to repair and to provide new facilities. And then lastly, how healthcare facility wash improvements impact mothers' health-seeking behavior or the health-seeking behavior of other patients. Again, that is an issue that we still need to explore further through research. So what are some of the previous and current wash and IPC activities in Uganda? So between 2016 and 2019, we had really a number of regional IPC and wash assessments in healthcare facilities. And these were situational analysis studies that involved a number of stakeholders. We had UNICEF involved, we had World Vision involved, we had CARE International involved, School of Public Health, where I work, was involved in many of these, as well as Emory University in the US. And these regional eyepiece and wash assessments were critical in informing a number of IPC and wash interventions across these regions. UNICEF and AMREF Health International, for example, implemented a number of interventions based on the findings that came out of these regional assessments. But besides that, we saw that a number of organizations were able to make a commitment towards the improvement of wash and eyepiece in healthcare facilities. These commitments were in response to the World Health Assembly communication that indicated that it was important and critical for stakeholders across the world to improve and work towards improvements in wash and IPC. And therefore, working with Global Water 2020, a number of organizations in Uganda were able to make those commitments towards improving wash and IPC in healthcare facilities. After doing the regional IPC and wash assessments in healthcare facilities, last year, just before around March 2020, that was like immediately after the COVID-19 first case in Uganda, we had the national eyepiece and wash assessment in healthcare facilities done. This was a rapid assessment, and together with the regional assessments, it helped to inform the development of the national wash/IPC guidelines. I highlighted this in red because these guidelines are not yet complete. They are still being reviewed. We have the draft versions that we are currently reviewing before we can finally endorse them and release them for public use. But important to note here is that the national eyepiece and wash assessment really informed the development of the national wash/IPC guidelines. But besides that, it also informed the integration of wash and IPC in the health management information system. We've also seen a lot of growth in research related to IPC and wash since 2016, between 2016 and today, a lot of IPs and WASH research, both formative and interventional studies in healthcare facilities have been conducted, and some of this research has been conducted by researchers at the School of Public Health where I work. What are some of the current research and activities in Uganda related to IPC and WASH? So as I mentioned earlier, currently we have the national WASH and WASH/IPC guidelines being developed. They should be finalized before the end of this year. We've also had WASH and IPC integrated in the Health Management Information System. WASH and IPC improvements in healthcare facilities during the COVID-19 pandemic, and really a number of stakeholders have invested in this aspect. Research on IPC status during the COVID-19 pandemic using the IPCAF tool is also ongoing. We are currently involved at the School of Public Health in a research that is looking at the impact of health and environmental cues on hand hygiene among healthcare workers. And this is a randomized controlled trial in 45 healthcare facilities. We've also had some research around the status of WASH in healthcare facilities during the COVID-19 pandemic, and I'll be sharing some of the results that we have from that, from this last bit of the research aspects. So this research on status of WASH and IPs in healthcare facilities during the COVID-19 pandemic was conducted last year, and the design was a health facility-based cross-sectional study that employed quantitative methods. We did this in 75 healthcare facilities in the Greater Kampala metropolitan area. This is an area that combines 3 districts, Kampala, Mukono, and Wakiso. In terms of the data collection tools, we use the M-Water survey tool, and we used structured interviews as well as observations in the health facilities. Data collection was carried out between October and November 2020, and data was collected through a general facility or ward observations where we used an observation checklist. But on top of that, we did some interviews with facility managers and administrators, and in their absence, we had to talk to the IPC focal person. The outcome variable here was IPC and WASH status in the healthcare facilities. Data entry and analysis, we collected the data using the Kobo Collect mobile application. Data was uploaded on the server, and descriptive statistics such as frequencies and percentages were used to present categorical data, while continuous data was expressed as mean and standard deviation. So this table gives us a summary of the facilities, the 75 healthcare facilities that were involved in the study. Majority of the healthcare facilities that were involved, 77.3, were actually lower level healthcare facilities. In Uganda, we have health center 3s, health center 4s, and hospitals. So lower level health facilities at the level of health center 3 were the majority. And again, majority of the healthcare facilities that were involved were public facilities or government facilities. And again, majority of these facilities were in urban or semi-urban areas. In terms of IPC in healthcare facilities, we looked at the presence of an IPC focal person or focal person in the healthcare facilities, and majority of these facilities, 90.7%, had an IPC focal person. In terms of whether this focal person had received some in-service training on IPC, 91.2% of the focal persons had received training. In terms of whether the IPC, whether the healthcare facility had an IPC program with a clear annual activity plan, we had only 49.3% of the healthcare facilities with a clear program and annual and a clear annual activity plan. This is not very good because the activities of the IPC committee usually depend on the annual activity plan. And if they don't have an annual activity plan, then it means that their activities will not be implemented well if they are to do that. In terms of whether the healthcare facility had an IPC committee, only about 86.7% of the healthcare facilities had an IPC committee, but unfortunately, some of those IPC committees were not functional, and some of those IPC committees didn't have a clear budget line to support their activities. As you can see here, only 32.3% of the IPC committees had a budget line to support their activities. In terms of whether healthcare workers frequently get IPC training, only 69.3% of the healthcare facilities reported to having healthcare workers getting IPC training. Yeah. So in terms of water service, 73 points, I will highlight the major issues here. I cannot, because of time, I will not be able to speak to all of the points in this slide and the rest of the slides. So in terms of the main water supply, piped water supply inside the building was the major source of water. As you can see, 73.3% of the healthcare facilities had piped water inside the building. But we also realized that rainwater harvesting was a common source of water, as it was used in 18.7% of the healthcare facilities. Unfortunately, 1.3%, which was indeed one facility, was using an unprotected dug well. In terms of water being available from the main water supply at the time of the survey, 94.7% of the healthcare facilities had water available at the time of the survey. Were they testing this water for E. coli to understand the quality of the water? Unfortunately, that wasn't the case. Only 6.7% of the healthcare facilities were testing the water to establish the microbial quality. In terms of sanitation service, type of sanitary facility used by the healthcare facility, about 32% of the healthcare facilities were using flush toilets or power flush toilets, but majority were indeed depending on pit latrines. In terms of the healthcare facility using improved toilet designated for women and girls, and whether these facilities were accommodative of menstrual hygiene needs, majority, 58.3% of the facilities didn't cater for that, unfortunately. A healthcare facility has at least one toilet or improved latrine stands for people with disabilities. That wasn't provided for in majority of the healthcare facilities, as only 16% of the facilities had a latrine or a stance that catered for the needs of people with disabilities. Healthcare facility has sanitation facilities clearly separated for staff and for patients, and for males and for females. That was provided for in 64.0% of the healthcare facilities, and fecal sludge was properly managed in majority of the healthcare facilities. In terms of hand hygiene service, as a healthcare facility, in terms of the healthcare facilities that had functional hand washing facilities within the 5 meters of existing toilet blocks, 66.7% of the healthcare facilities had functional hand washing facilities within 5 meters of the existing toilet blocks. In terms of facilities that had functional hand washing facilities with soap and water or hand sanitizer at all points of care, 70.7% of the healthcare facilities had that. In terms of healthcare facilities that undertook routine hand hygiene compliance monitoring, majority didn't undertake that. 62.7% of the healthcare facilities were not undertaking routine hand hygiene compliance by the time of the study. That was last year during the outbreak of the COVID-19 pandemic. In terms of, for those few that were involved in undertaking routine hand hygiene compliance, we wanted to understand the frequency of doing those hand hygiene compliance assessments through observations, and we realized that a majority of the facilities, 18 out of 28, were actually undertaking those observations every 3 months. In terms of healthcare facilities having functional hand washing facilities with soap and water or hand sanitizer at the main entrance or the gate, majority, 81.3% of the healthcare facilities had functional hand washing facilities with the necessary supplies at the gate. In terms of hand washing with soap and clean water or hand rub with the hand sanitizer being enforced at the main entrance, indeed, majority of the healthcare facilities, 70.4% of the healthcare facilities were enforcing the practice of hand hygiene at the entrance of the healthcare facilities. In terms of environmental cleanliness, healthcare facilities, in terms of presence of guidelines and procedures or SOPs for cleaning surfaces, these were available in very few of the healthcare facilities, 26.7% of the facilities. When it came to presence of a cleaning roster, again, very few facilities, 33.3% of the healthcare facilities had a visible cleaning roster or schedule displayed. In terms of healthcare staff with cleaning responsibilities, receiving training, majority of those, 65.3%, had received the required training. And in terms of the facilities having enough supplies used for cleaning in the labor and the delivery wards specifically, on majority, 84.0% of the healthcare facilities had sufficient supplies. When it comes to beds and mattresses being cleaned between patients, majority, 92%, reported that their beds were cleaned between patients. Evidence of open defecation at the healthcare facilities. We had, unfortunately, this shouldn't happen in healthcare facilities, but we had 4% of the healthcare facilities where there was evidence of open defecation. In terms of waste management, when it comes to healthcare facilities having uncontained solid waste on facility premises, majority of the facilities didn't have uncontained solid waste on the facility premises, whether the facility was segregating the waste into appropriate bins. In the majority of the healthcare facilities, that's 88% of the healthcare facilities were segregating the waste in the appropriate bins. When it comes to having a functional incinerator for the treatment of the infectious waste, unfortunately, majority of the healthcare facilities didn't have functional incinerators, and therefore they depended on other companies, external companies that had to collect the waste and take it for treatment off-site. And when it comes to presence of placenta pit, majority of the healthcare facilities had the placenta pit. In terms of the conclusions, majority of the healthcare facilities had IPC committees. However, some of these committees were not functional, and some of them didn't have a clear budget and a clear annual work plan. A third of the infection prevention, a third of the IPC committees were not supported by the budget line, as I've already mentioned, and almost all healthcare facilities in the Greater Kampala metropolitan area had achieved a basic water supply. However, these healthcare facilities still grappled with the lack of alternative water supplies, most especially during periods of discontinuity or scarcity. Thank you. That brings me to the end of my presentation.
Thank you, Richard. It was very informative. I'm just going to give a 5-minute break just for the interpreters, and then we will hand over to Yolanda. She was on the call, but we couldn't see her. So thank you for her to make us notice of the 5 minutes break, and then Yolanda will be able to start with hers. It's just for the interpreters to give their voice a little bit of a break. Thank you. It is now 12:35, so we'll start at 12:40, and then Yolanda can start with hers. I'll introduce her before she starts, so we will just give them a few minutes break. Thank you. Just to let everybody know, we're not lost. We just gave the interpreters a 5-minute break just for their voices to be resting a little bit between the presentations. So it's now nearly 12:40 or 1:40 according to the time slot, depending from where you are. I would like to introduce Yolanda Walsh, which is a nurse by profession, but she's a critical care nurse, and she felt the need to explore health science education and develop organically into addressing issues around patient safety, and it led her to the science of quality improvement. And she, since 2010, has worked, designed and led facilities and improvement in number of large-scale quality improvements in large private groups in South Africa. And the main focus was on the theme of improving systems and cultures through the application of improvement science. She was also part of the Best Care Always campaign. And I'm going to hand over to Yolanda to just tell us a little bit more about herself, and then she can take the forward with the slides. Thank you, Yolanda. Over to you.
Great, Anna. Thank you very much. And thank you to everyone. It's a great privilege to be speaking with you. Just checking you can see my slides.
Yes, we can.
Okay, excellent. All right, so thank you for the kind introduction. I was involved and eventually chaired a quality improvement program called the Best Care Always campaign in South Africa, which began in 2009 and was very active in the South African setting in both the public and private sectors from about 2009 to the end of 2016. I worked for a private hospital group, which at that stage had about 50 hospitals, and I was charged with reducing healthcare associated infections and, in inverted commas, implementing the bundles for reducing CLABSI, CAR-T, VAP, and surgical site infections. And just want to see, wanting to move my slides along. Let me go. There we go. Okay. All right. So I'm sure that that you know about care bundles. So the presentation is based on the assumption, not knowing the audience very well, and having had input that the audience is quite a varied audience. I've chosen to speak specifically about CLABSI in the prevention of bloodstream infections and the CLABSI bundle, and looking at that within the context of COVID-19 and beyond. So when it comes to evidence-based practice and evidence-based healthcare, you can look up guidelines, and in those guidelines, there will be 25 to 30 evidence-based interventions. It is very difficult to reliably implement 25 things. The beauty about a bundle is that it is a collection of interventions, 3 to 5 interventions in a bundled approach. And when these things, just those 3 to 5 things, are implemented reliably, it has a dramatic impact. It's far better to reliably implement 5 interventions than to haphazardly implement 10. Right, so that's the thing with bundles. They're proven to work. They're proven to reduce particular issues, and the reason why they work is because they change the assumption that evidence-based care is being delivered reliably. So once you start measuring how well these things are done each and every time, you'll see that that's actually not the case. So what it does, by trying to implement the bundles, you promote awareness of the whole system, and that the team must work together if you're going to design the system to be more reliable. And they do promote the use of improvement methods, but there is a whole science of improvement to redesign those care processes. But starting on a small scale, it doesn't have to be that intimidating. And just a little bit that I added, bundles make it doable. So often when you're charged with, oh my goodness, how do I reduce central line associated bloodstream infections, the bundles are a really, really good place to start. So the CLABSI bundles, those that were initially developed in the mid 2000s and late 2010 were the insertion bundle and the maintenance bundle. And the insertion bundle, the example I'm going to speak about in this particular webinar, the insertion bundle focused on maximal barrier precautions with insertion. So it was a lot to do with the doctor inserting the central line and the IPC principles applied reliably, and not individual practitioners deciding what they would and would not do. For example, they would drape the patient from head to toe versus not drape the patient from head to toe. So it was to highlight that these things needed to be done reliably if you wanted to reduce the likelihood of a bloodstream infection with the insertion of a central line. And then the central line needs to be maintained in a particular way. And I'm not going to go into the actual elements of the different bundles. I think my key message in this presentation is that it's really important to remember what you're trying to achieve. The bundles are a beautiful way to start. But if I had to ask you, what are you trying to achieve? Is it A, to implement the CLABSI bundles, B, to ensure bundle compliance, or C, to dramatically reduce CLABSIs? C is what the answer should be. I've had some interesting experiences where if you lose sight of what you're actually trying to achieve, that you're actually trying to reduce a particular healthcare associated infection, and if the emphasis shifts to implementing those bundles or making sure that we've got excellent bundle compliance, you can lose a lot of the learning in that system, and you can lose teammates, and I'll explain what I mean by that. So there's a family of measures in improvement science for you to know whether or not you're achieving your aim, and this would be classified as a SMART aim. It's specific, it's measurable, possibly achievable if you've actually analyzed the system well and you understand what the issues are and your testing changes. And it's time bound, it's quite specific. So let's say we were starting that now. We want to reduce the CLABSI rate with 80% by February 2022 as an example. One of the three types of measures are outcome measures, and they tell us whether we're getting closer to our aim. Now, remember, our aim is not to implement the CLABSI bundles. Our aim is to reduce the CLABSI rate by a very specific number. And examples of those would be actually measuring the CLABSI rate, or for something, it tends to be quite a rare event if you measure days between CLABSI episodes. The second group of measures within this family of measures are called process measures, and they tell you whether you're implementing the desired changes every time. For the bundles, these process measures are bundle compliance. I think what's important to remember is that you may need to go beyond the bundles. It's likely that implementing the bundles is not the only changes that need to be tested and implemented in order to see the necessary change. There may be very specific, very context-specific barriers and issues in your setting. And the last set of measures in this family of measures are balancing measures, and they tell us whether or not we're causing any unintended consequences. So one of the things with the central line bundles is that you don't want to unnecessarily insert a central line to begin with. Okay, so if there's no central line, you can't get a central line associated bloodstream infection. But with that comes the possibility or probability of peripheral lines becoming tissued. And central lines were developed so that they could more reliably and safely, that you had a route to administer drugs that were potentially cytotoxic, etc. So one of the things you've got to look at are peripheral line extravasations, if those are happening, and any adverse events related to line placement. When you go into the recommendations, the evidence-based recommendations for preventing central line associated bloodstream infections, one of those is that inserting it into the subclavian vein has a lower infection rate than cannulating into the internal jugular. But the subclavian route can result in other adverse events such as hemopneumothoraces, etc. I will admit, when I hear the term compliance, and it's from doing improvement work for the last 12 years, when I hear the word compliance, the little hairs on my back go up a little bit. Compliance is fantastic for quality control purposes, for seeing if you're at the desired level. Not necessarily for quality improvement if you're not using the compliance data correctly. My approach to using compliance data is that I have a deep respect for the people and the system in which this data is being collected, and that this compliance data, which looks at whether or not our processes are being implemented reliably, that data is approached with curiosity and learning, and is not for judgment. I'm always very cautious of jumping to conclusions and assigning causation based purely on data. There has to be a deeper analysis for you to be able to see what's happening. This is a poster presentation that was presented at the inaugural Quality Improvement Summit in Cape Town, I think 8 years ago already. It was entitled Engaging Physicians in Quality Improvement, Hard Lessons from Implementing the CLABSI Bundle. The lead author started writing up the abstract for submission, and the initial story was about one of the nephrologists who was non-compliant. And it was actually only in the process of writing up this abstract that she actually asked the nephrologist what had resulted, why the reduction in compliance. Now, when I see data like this, I get very excited. And I get very excited because it tells me that there isn't a culture of fear. There isn't a culture of reporting. And we have a situation here where we can honestly now learn from what is happening here and why why would there have been such a dramatic reduction in compliance to the CLAPSI insertion bundle when initially we were sitting with beautifully, excellent bundle compliance. Right. I use compliance data to begin understanding the barriers. And this is an excerpt from the poster, which I'll read directly. It says his reasons for not complying included not finding any supporting literature for the bundle. Now, bearing in mind this was very early in 2010, there's a lot more data now. Rapid insertion of central lines were a show of competence and prowess when this particular physician was in training. And the increased time required by the insertion bundle impacted on his daily practice. This particular doctor inserted about 70% of all central venous catheters in this hospital. His unwillingness to stick to the elements of the bundle was made worse by unstable staffing. So those assisting him with the insertion, they themselves did not necessarily know what they were doing. There was a high staff turnover. The unit manager had resigned, and he was not confident that staff would adequately maintain the lines after insertion. So here he went to major efforts to insert this line according to evidence-based practice, changed his way of doing things. It's very different to what he was taught as a student and studying in academia. And then he had very poor communication and interaction with the hospital management about the compliance, and this hardened his attitude to the project. Compliance should be the starting point of understanding barriers, and then overcoming those barriers is absolutely critical. You're not going to get good compliance if barriers to poor compliance are not addressed. It was initially thought that a letter from the hospital's management had changed his compliance, but what actually changed his approach was feedback from his peers. He saw an improvement in staff competence with the employment of an ICU trained unit manager that made the unit more stable and functional. There was greater visibility of nursing management in the unit and contact with the physician on his rounds, and this promoted teamwork and communication. And then he was more compliant. Yeah, so there's often a lot more. It's not a superficial reason or superficial reasons when changes in compliance happen. So coming back to COVID-19 now, and just some central line issues and central line specifics. On the right-hand side here we see an ICU patient who's intubated. He's got his endotracheal tube in there. And interestingly, this is just a photo that I got off the web. This patient has a central line in the internal jugular, which is actually not what is recommended to reduce CLAPSI. And you'll see that there, these infusion ports, these lumens, they're quite easily accessible here. On this particular line, you don't see many extension cords or anything like that. So what has changed in COVID-19? So, sure. The majority of patients are turned into the prone position. And suddenly the central line, the length of it, for example, becomes an issue. So you saw that those lumens are actually quite short. So there's now extensions required. There's increased connections, increased ports. The patient, if it's inserted into the subclavian, sort of just below the collarbone, the patient is actually lying on that central line. And not only is he lying on it, we position. This is a very this is not a large patient. A patient with a higher mass, you have to have the abdomen. You can't be lying on the abdomen and chest. So we have to position pillows under the shoulders. So basically the insertion point of the central line is actually lying on a pillow. And securement of the central line becomes a real issue. So hospitals, many doctors have moved back to actually stitching that central line in, whereas previously it may only just have been held in place with a really good securement device. So this particular situation changes the dynamics, may change even what is happening with your bloodstream infection rates. And some things might actually make compliance a little bit of a challenge. Now, the thing with you'll see there's a picture of gloves coming up there now. With COVID-19, you're always applying contact and droplet precautions. And these patients may be in isolation rooms. The placement of the gloves make a huge difference. So as you enter and come towards the patient, you're donning, you've got your apron and you've got your gloves on. You can't do an alcohol-based hand rub on these gloves. And if there aren't gloves at the point of care in the room, then you're having to leave the room to put on a new pair of gloves. So it requires incredible awareness that when you first enter and come into the patient zone, that you are going to the central line. If you've got an infusion, or if you've got something that you're administering or you're changing a line, that you're not doing a whole lot of other things first before interacting with the central line ports or with any of the infusions. So even decisions around where gloves get placed, the emphasis on not wanting to discard a box of gloves when terminal cleaning happens, etc. Those are all things that influence whether or not it's easy or easier to do the right thing. And I don't want you to underestimate healthcare worker exhaustion and workload. Nurses are in the South African setting and from elsewhere in the world, nurses have 2 to 3 times the patient load than what they would have had pre-COVID. And that means that people take shortcuts. If you need to do something, if there's so much that needs to get done, unfortunately, people do take shortcuts. How do I know all of these things, or how did I see all of these things? Well, when COVID-19 came along, I volunteered to be redeployed back to a particular hospital. And as a critical care nurse, hadn't practiced in quite a few years on the front line, I went back into a COVID ICU and got to observe and witness a lot of these barriers and a lot of these issues. Also, it isn't just CLABSI that has COVID-19 implications. on HAIs. Also got to bear in mind that when it comes to VAP prevention, ventilator-associated pneumonia prevention, mouth care in these prone patients is quite challenging and can be a barrier in itself. Having the head of bed at 30 degrees or greater than 30 degrees results in the patient sliding down and pressure on the abdomen, so that's a challenge. And the securement of the urine catheter are just some of the issues. So in closing, if I can leave you with this message, and that is that situations change. And only if you're collecting data, so you're collecting your data, you're tracking it, you're plotting it, you're annotating it, which basically these little messages or little notes above your data, that you're analyzing it as a team, will you be able to see when certain changes within the context have had an implication for your particular rate, for example, here the CLABSI rate. And then there are data specifics, which I can't go into right now, but the importance of understanding your data, understanding run charts and the science behind run charts, and when something is a statistically significant change and when it's not. So it's not static, and it won't ever be static. So you might have achieved amazing CLABSI bundle compliance, but COVID might have changed that. And going forward, there may be other situations that also impact on a particular HAI and its likelihood of occurrence. And I'm going to, if you would like to contact me, that is my email address, and and my Twitter handle at Yolanda Walsh. Thank you so much.
Thank you very much, Yolanda. I think this is a different angle, but it's so great to see this as well. And for us to just look at something and not just the normal what we do and think about PPE as COVID. I'm going to hand over to Lizzie, and Lizzie will take some of the questions that's in the Q&A box, and she will direct it to certain people on the panel for them to answer. And I just want to let everybody know, I know there's a lot of questions about the presentations. They will be posted on the websites, and if you've attended or registered, you will get them through the mails as well. And as Yolanda have said, her information is available there, and we can give that to all of you, so that we will take a bit further. I think as well that, we're running these series since last year already, and it's every 6 weeks. It's one series runs over 6 weeks. You have to attend at least 4 out of the 6 and stay on for 60 minutes to be able to get an attendance certificate. If you're interested in real IPC training, you need to contact us, and we would be able to guide you into, depending on from which country you are. ICAN does do infection prevention control training. We've got different types of training, so you can contact us as well. But I'm going to take it over now to Lizzie to handle the questions about the presentations and what is in the Q&A box. Thank you, Lizzie. Over to you.
Thank you, Anna. Good morning, good afternoon, wherever you're joining us from, and welcome to our Q&A session. And thank you to the presenters today for very informative presentations. So as we start the Q&A session, we'll direct my first questions to Dr. Richard, while Yolanda also takes a breather. So the first question directed to you, Dr. Richard, is in terms of the study that you presented, was it a deliberate action to consider more urban facilities than the rural ones? Over to you, Dr. Richard.
Thank you, Lizzie. So it wasn't deliberate to consider more urban facilities than rural facilities. As I mentioned in my presentation, the study was conducted around the greater Kampala metropolitan area, which includes the 3 districts of Kampala, Uganda, and Wakiso. So majority of that the great Kampala metropolitan area is urban, and therefore it contributed majority of the facilities that were involved in our sample size. Thank you.
Thank you, Dr. Richard, for that response. The next question also directed to you is, did you look at the designs for the hand washing stations? For example, the tapes, were they using elbow operated or pedal operated tapes? Over to you, Dr. Richard.
Thank you. So we looked at that, though I didn't make a presentation on all of the results that we have from that study. So we looked at the different types of hand washing facilities. Some were elbow type, some were pedal operated, but majority were elbow operated.
Thank you so much for that, Dr. Richard. And just one last question before I also address some to Yolanda. What is the improvement model that you are using to address these gaps and looking at the sustainability issues?
Lizzie, thanks for the question.
Oh, sorry, Yolanda, that
yes.
One is the last one for Dr. Richard, and then after that, yes, sorry about that,
excellent.
Yolanda.
Thank you, thank you, thanks. Thanks, Lizzie.
Dr. Richard, may I repeat the question again?
Hello, sorry, my internet had a problem.
Oh, yeah.
So,
okay.
If you can repeat the question for me, please.
The question is, what is the improvement model that you are using to address the gaps that were identified in the study, and with regards to sustaining this improvement? Thank you, and over.
Yeah, so currently there are a number of models for improving WASH and IPC challenges in healthcare facilities, and many of these are proposed by the World Health Organization. One of the models that is being used is the WASH Fit model. A number of organizations, including WaterAid, UNICEF, are using that model. And I think it works so well. But beyond that model, there are a few other models that WHO has proposed, and I think they can be used for improvement of WASH and IPC in healthcare facilities. The WASH Fit is a good model. Thank you.
Thank you, Dr. Richard. My next question is addressed to Yolanda. It says, how can we maintain the CLABSI under control in the hospital setting? That is mainly in the ICU. And the participant is asking in terms of the surveillance plan, using the surveillance plan. Over to you, Yolanda.
Sure, so I'm not an IPC expert. I should have put that in as a point of departure right in the beginning. So, Lizzie, maybe if you could clarify for me, if the person could clarify for me, is this in measuring compliance data in the ICU in the setting of COVID-19? Is it that when it comes to surveillance that it's an issue about going into the ICU? If I could just get some clarity on that. It's difficult for me to answer.
Okay, thank you for that, Yolanda. I think probably they just want to find out the interventions that you can put in place using the data if you're seeing a rise in the CLABSI rates when you are in the ICU, and what possible plans in terms of surveillance would you put in place?
So I think the most important thing is that whenever you're trying to, so the data tells you that you've got a problem, but understanding the problem, that knowledge, that learning will come from the frontline staff themselves. So I think it's absolutely critical that you engage with the doctors and nurses actually working in that ICU, and so that you understand what is contributing, and that any ideas for improving the situation come from the frontline staff. So I've had lots and lots of experience where we come up with plans and ideas that we think will be an improvement, but it may not be addressing the particular issues in your context. So for the person who posed the question, the best thing would be to actually go and engage with those doctors and nurses and ask them what they think is contributing and what ideas they think should be tried to improve the situation.
Thank you, Yolanda, for that. And also open it to the rest of the panelists. Anna, Jacob, is there any additional information?
I would agree with what Yolanda said, Lizzie, but I would also say, depending on what type of surveillance you want to do, and do you know about your baseline, and then pick up and see, was it increasing or not? So it's important, I think, to know exactly from where you start and what you want to do with that. But I think it's always good to talk to the IPC committee and the people working with them in the area, and they can take it in working as a team and find out how they can work through that. I don't know what, Jacob, you've also done some surveillance. So Jacob, what do you think of? I see I've got Silas on here as well from Africa CDC, and we've got Dr. Zwanda on as well, so maybe she can also give some feedback.
Excuse me. Thank you. Excuse me, please. Sorry. Thank you, Anna and Lizzie. We just started a few months ago, so I really don't have much experience to share in this domain, but I fully agree with what Yolanda said and what Anna has also said. Thank you.
Thank you, Jacob, for that. The next question is back to Dr. Richard. In respect to the previous presentation, that is your presentation, Joseph wishes to understand how these IPC WASH interventions have helped to reduce or to accelerate the spread of COVID-19 in Uganda. Over to you, Dr. Richard.
Thank you. I can say that we've not done studies on that link the presence and functionality of WASH and IPC infrastructure to transmission of COVID. What we know as of now is that the availability and utilization of WASH and IPC infrastructure in healthcare facilities has increased, but we don't have that evidence that closely links the availability and utilization of those facilities to transmission. Generally, we know that if those facilities are available and they are being utilized well, that definitely transmission of COVID-19 will reduce, but we don't have the evidence from the healthcare facilities. Thank you.
Thank you for that. And the next question also directed to you. There's a participant who says they were not very clear on the hand hygiene management in the healthcare facility. There was somewhere where monitoring had a lower score. I'm assuming that is the compliance. And towards the end of the presentation, you mentioned hand washing happening at the point of entry. May you kindly clarify further what you meant?
Yeah, so the guidelines for hand hygiene for healthcare facilities, especially during the COVID-19 pandemic, require that one, hand hygiene facilities should be provided at the entrance, at the gates, at the entrance and at the exits of healthcare facilities. So you should have a functional hand washing facility at the entrance and at the exit. Secondly, hand washing facilities should be provided within a distance of 5 meters from the toilets or sanitary accommodation facilities. And then thirdly, hand washing facilities or hand hygiene facilities should be provided at all points of care. So I think I talked about all of these three, and I don't know exactly what caused the confusion, but the purpose of talking about hand washing at all these 3 points was to make sure that we bring out the compliance issues related to the WHO requirements in terms of hand washing facilities being provided at the entrances, at the within a distance of 5 meters from the toilets, and at all points of care. Thank you. And for each of those 3 points, healthcare facilities had different scores, which I talked about during the presentation. Thank you.
Thank you, Dr. Richard, for that. Whilst you take a breather, my next question is directed to Yolanda. How can we determine that a specific infection is Klebsiella associated? There are many sources of nosocomial infections in a clinical settings. Over to you, Yolanda.
I'll rely on Anna to come in with the definitive answer. But if you apply the surveillance definitions, I think it's the CDC surveillance definitions, you're able to classify whether a bloodstream infection is central line associated or not. There's very intricate and very specific criteria in order to say whether or not something is central, whether a bloodstream infection is central line associated or not. Anna, if you could please assist the non-IPC practitioner.
Yes, thank you. At the moment, we're still using the CDC definition, but we did found that it's not always that easy in Africa because they rely a lot on laboratory findings and all of that. And not all our facilities do have laboratories that can do that. So at the moment, Africa CDC and ICAN and Africa Union and all of them are working together to put together definitions for hospital-acquired infections or healthcare-acquired infections that are context-specific for us in Africa and easier to use. So it's at the moment, like Yolanda said, very difficult because we rely on the specifics of CDC. And if you go onto CDC's website, you will be able to see the specific requirements to be able to classify it as a CLABSI or even a Couch or VAP or Bundle, one of the infections, depending on, how it was started and all the information you need before the time. So I think at the moment, it is still difficult for us, and we found it, especially in Africa and in more rural Africa, it's so difficult for people to really determine. So they go on to clinical signs and symptoms at the moment to make that definition and then treat the patient accordingly until they can get the more laboratory confirmed diagnosis from that. But that's at the moment all we can do. And I saw there was more than one question on that. So yes, that's what we do. And yes, there's many sources of that. And that's why we promote infection prevention and control to be as a norm always, everywhere in your healthcare facility, and not just during the pandemic. And that's why we want to make sure that people understand what IPC is all about, and not just when they're, but rather be proactive instead of reactive. And then also, if there's any French people, I do have Prof. Azus on this session as well, but he will run the French session tomorrow. So there will be a French session tomorrow at 1 o'clock South African time or 2 o'clock East African time, that the French people will be able to also have their questions answered. I know there's still a few people that raise their hands. It's to answer raised hands. So if you can please just put your question in the Q&A box, it's so much easier for us to take it from there. Thank you.
Thank you, Yolanda, and thank you, Anna, for that. The next question goes to Dr. Richard. It said, in conclusion, you said that some healthcare facilities don't have functional IPC committees. So what are some of the best practices to those that don't have functional IPC or WASH activity or services? Over to you, Dr. Richard.
I didn't get the question clearly, but basically, IPC committees, all healthcare facilities are supposed to have IPC committees. And as part of that, these IPC committees are supposed to have regular meetings. And whenever they have those kind of meetings, they are supposed to get the minutes of their meetings. Besides the meetings, they're also supposed to have a clear annual work plan in terms of the things that they are supposed to do, to implement within the healthcare facilities. They are supposed to have a clear budget, which is endorsed and approved by the administration of the hospital or the healthcare facility. They are supposed to organize trainings for their staff within the healthcare facility. So those are some of the best practices. But what we saw in our study is that whereas a number of health facilities had these committees, in some of the facilities, the committees were on paper, but they were not functional. And what we mean by them not being functional, they didn't have meetings, they didn't have minutes or evidence of meetings, they didn't have an annual work plan. So those are some of the issues that help us to determine whether an IPC committee is functional or non-functional. Thank you.
Thank you so much, Dr. Richard, for that very detailed answer. And it has actually addressed some of the other questions that were in the Q&A box that we're asking on the functionality of the IPC committees. And at this point of time, I would like to thank all the presenters and the panelists for a very informative session. And we promise that for the questions that still remain unanswered, they will be posted and we will hand them over to the presenters and the rest of the panel so that they can be answered and be sent to you when the recordings and the slides are being sent. Thank you so much, and I'll hand over to Anna for the closing remarks.
Thank you very much, Lizzie. Yes, I know there's still quite a few questions. Susan, that is in the background, will collate all the questions that are still unanswered, and we will make sure that we do get the answers and send it out. I just want to also remind you guys that the presentations will be posted on our websites, ICAN and Africa CDC. It just takes a few days to get all this information through. If you're registered, Susan normally also send the presentations in a PDF format through to all of you. And then just to also remind you about the French sessions that we have every week as well, but only on a Thursday. On the Wednesdays, we have the English one with the Portuguese and Arabic interpretation. So we're looking forward to see all of you next week, again at the same time. And then we're going to have a very interesting walkthrough facility on IPC as well, and some panel discussions. So please do attend. And if there's anything else that you need, you can contact us at ICAN directly or Africa CDC directly, and we will see how further we can help you. Thank you very much for our speakers, and thank you for our panelists for your time to be on here. Thank you to our two interpreters. Thank you very much for everybody, and have a good afternoon. Goodbye.